Hi, my name is Ashley Martinez, and today I'm going to be talking about the Edward Hanan and New York's CABG surgery reporting system case. I want to start off with step 1, which is the background information, the full rundown of what a CABG procedure really is to kind of set the scene for you guys. So a CABG procedure is used for a coronary artery disease caused by blocked or narrowed arteries, and this can cause buildup, which restricts the heart from getting the necessary oxygenated blood that it needs to function. And so this can be very life-threatening, hence why people get this surgery a lot. That now there are less minimally invasive procedures. And back then, the problem was that hospitals did not have a reporting system, which led to many unnecessary deaths and substandard care. So because the hospital wasn't held accountable for its mortality rates, or it wasn't surveillanced or monitored, hospitals didn't really feel the need to provide good quality care. This became a problem for the 15,000 CABG patients that resided in New York, which is where this whole case took place. And basically the patients that were more at risk were the patients with more advanced disease, or who were of older age or had comorbidities, because essentially these patients weren't able to recover at the same rate as their younger counterparts. And Edward Hanan, who had a PhD in operations research and was also a public health official, is the person who made a database for CABG procedures in 1988. To step 2, which is analyzing the current situation. So at the time, there was a lot of social controversy surrounding the release of data, which involved a bunch of patients. And this especially upset the medical community and surgeons, as they were afraid that their reputation was on the line, and they were also afraid of legal consequences. The factor was culture, so data had never been released to the public, so the validity of the data had to be ensured by the Department of Health, and really this was just to maintain the public's trust. Another thing that had to be taken into consideration was the demographics of the data. So this involves, the socioeconomic factors involved in CABG mortality rates, so where lower income areas affecting, data differently, and just other health demographics as well. And then here I have a SWOT reporting system. And so I want to go over the strength, which is that hospitals felt the need to improve quality care and safety with this database implementation, as they were now being held accountable and they were basically being put onto the spotlight. A weakness for this was that some hospitals stopped CABG surgeries because of mortality rates. So because this database really did shed a light on mortality rates, a very small amount of hospitals completely stopped doing the surgery. So that my guess is that they didn't really want to be, known for such a thing. And then next is opportunity data, which is that data could help compare hospitals and treatments, which meant that people had more information to publish studies. So that was scientists and professionals, but also, patients had more hospitals and treatments to choose from. And this helped them determine, hey, I want this surgery, or, if this hospital has better mortality rates, then maybe they may choose to go to a different hospital. For the T part of SWOT, this was that there may be resistance from the medical community, and this was more of like a social cultural thing that people kind of just didn't want that to change, especially the medical community and those being affected by the situation. Moving on to step 3, which is prioritizing issues. So basically, high mortality rates from the CABG surgery were from the lack of publicity, resulting in the lack of hospital accountability and inadequate care. And like I said, this was because hospitals, weren't really putting out there what they were doing or their mortality rates, and people kind of just had no idea that this sort of thing was going on. They weren't being well informed. And so high mortality rates were actually not from having sicker patients, which is what a hospital actually did claim. They claimed that they had sicker patients, and that is why they had more deaths than other hospitals, but that was actually not the case. I think this is why this was really important to hold hospitals accountable. So moving on to just analyzing alternatives. So I felt that national databases could be included instead of local or state databases, and I want to show you the health model. And so basically, here we have susceptibility. So a lot of states and hospitals, there's always that question of, are these places more susceptible to CABG-related deaths, whether it be from, economic factors or geographical factors. And then next is severity. So if a state had higher mortality rates, well, what will its consequences be? So there's always that case of how severe are some cases more severe than others, and if so, do they bear more consequences? And then benefit. I feel that broader data may provide more accurate statistics on CABG surgeries as well as just other surgeries in general, and this can help, create more useful data that may help save more lives. And then next up is barriers. Will the cost of a huge database be a concern? And I feel like this is a very important question because running a huge database like this takes a lot of time and effort. And then next is action. The public's trust can trigger a response. So I feel like if we were to implement a national database instead of a local or state one, public may be more supportive of this because they have more accurate data and they have more data to go off of. And then next is self-efficacy. With national and maybe international cooperation, we could get other states or other countries to do the same, and this can kind of trigger like a sort of domino respect, in which different places gain the confidence to put in this database for themselves as well. And then the next alternative I want to look at is the performance-based reimbursement, also known as the P4P, or the pay for pay. And I use the social ecological model. So I want to start off with individual, which is that providers have a financial incentive, may provide better quality care because people are being rewarded for their actions, and this may help motivate people. And so the next part is interpersonal, which is where hospital staff evaluations can lead to improvements on group or individual performance. And I guess this is kind of self-explanatory, but when you have incentives, people telling you that you're doing a good job or that you need to do better, this may motivate you to in fact do better. And then next is institutional, and this is for competitiveness among institutions. So hospitals get to keep skilled healthcare providers, and this is beneficial both for the healthcare providers and for the hospitals. And then next is community. It's not really a problem, but I think it's something that needs to be mentioned, is that local hospitals will need to be better supported, especially in affected populations. So if you have a lower income community, obviously this community will have to be better supported than a more financially stable community. And so I think this is another important thing to note in a situation like this. Moving on to step 5, which is providing recommendations. These are kind of just things that I thought of when looking at my sources. So I thought that instead of a national or a state cooperation data, we could have an international one. And this will have all countries involved in a massive database to determine what procedures are the safest for certain group populations. So, this could include techniques or newer techniques, especially with all the developing technology. So including this in an international database could be very helpful for studies and just for people in general. And then the second thing would be funding to ease out health disparities. And so this is just to prevent deaths from CABG procedures and improve healthcare quality. And we really have to be mindful and acknowledge that health disparities are a thing. So we should be funding lower income areas to prevent further mortality rates and just help the population in those areas in general. So step 6 is the action plan. Basically, I was kind of trying to say that using the pay for pay method to provide incentives for hospitals and staff, can lead to greater, I want to say, benefits if it were to work. And so this includes having insurance companies or government organizations fund low mortality institutions, and then have groups from each hospital oversee these fundings. And so here, a timeline of what I wanted this to look like. And so starting off with month 1, hospitals could establish an overseeing committee. So, the hospital would gather a trained group of staff, which would into contact with insurance companies or government organizations and oversee anything that having to do with this matter. And then during month 2, hospitals would enter into the competition, those who did want to enter, because not every hospital has to. And then within a year, the winning hospital gets its money. And then by the end of the year, each committee reports their findings. And then from this, we can see, how can this program improve? Is it really working? And etc. And then for month 13, we would repeat. 7 is just my conclusion. So in Australia, I saw that they had lower mortality rates for CABG procedures, and I searched up why, and it was actually because they had better disease prevention. So instead of focusing on the aftercare of coronary artery disease, they decided to prevent this disease from happening at all. And they also had very good emergency care, as long as specialized coronary artery disease units where people focus solely on patients with this disease. And then my opinion is that while stating reporting systems get the job done, other things may be of help to improve quality care and decrease mortality rates. So instead of focusing on just one idea, we could combine multiple into one, and this would be the database along with funding lower income communities, increasing an international database to provide more information, find incentives for healthcare workers, whether that be paying them more or with something else, and then disease prevention instead of focusing on how to cure the actual disease, and then using technological advances to our need. And then these are my references in APA format. Thank you.